Good evening to everyone present here with us today. This is Sriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Rajesh Chandra Mishra. Sir is MBBS, MD Medicine, FMB, CCM, ED, EDI, FCCP, FCCM, FICCM, then FICP. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is beating dengue strategies to save life. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
So, good evening and thank you, IGCP, for giving this opportunity once again. Dengue, one of my most favorite topic, and whenever I see that people die due to dengue, I really feel that somewhere down the line we are not able to do our job for educating people about the dengue, how they should be managed on day one, day two, day three, or day five, or what strategy should be adopted that people should not get complicated. Dengue is not disease where mortality should be more than 1%. That also too much. I mean, if we really follow proper protocol, if we just a little bit careful, we do not give treatment which is not needed, rather than we monitor the patient properly and we follow very simple protocol and know what kills this patient. I personally feel that we can reduce the dengue mortality to 0%. Almost we can wipe out. Day before yesterday only I heard there was a very young cardiac surgeon who succumbed to dengue. And whenever I see how they were managed, I really feel very bad. How come people are not um updated themselves on the basic understanding about dengue development and what they should do, what not they should do. So, with the help of a case, I'll try to get you insight that from the OPD till outdoor or till indoor emergency and even in ward and then everywhere, what should be done for managing a dengue patient. And I hope that I will be able to give you insight. Medicine. Okay. So here is the case: 70-year-old male complains of high-grade fever with body ache, no other discomfort, temperature goes up to 105 degree with chills and rigor, no sore throat, no skin lesion, no urine problem, no travel, no pets. Seen by a GP, he prescribes paracetamol 650 mg metaverly, ciprofloxacin 200 milligram BD, send NS1 CBC SR CRP, send him home, no record of the vitals. So the first thing when somebody, a young patient comes to you with a high grade fever, without specific signs, just fever, no tachycardia, no tachypnea, you are saying he doesn't have any other problem except fever. So I strongly urge people not to give antibiotic because these are the viral fever, and if you give antibiotic to viral fever, you are going to do more harm rather than benefit. You are going to suppress immunity. You are going to induce multi-drug resistance infection in community. Sending investigation is absolutely appropriate. At least you send for a fever patient CBC, SR, CRP. Differential count can guide you to a lot of things. It can really tell you clearly on day one that if you are dealing with viral or bacterial infection just by looking to the neutrophil count, or lymphocyte percentage, or eosinophil percentage, or monocyte percentage, even counts is normal. ESR-CRP also gives us a marker. And NS1 was sent as general practitioner sends everywhere. So when you send this kind of patient home, at least ask them to record heart rate, blood pressure, temperature, at least charting for every 4 6 hourly, and if possible, monitor oxygen level. If you are monitoring this thing and not giving any medication, that is the perfect thing. And give paracetamol at least proper dose. If somebody has high fever, more than 101 degree fever, give paracetamol 650 milligram 4 hourly for adult, or 6 hourly, minimum 6 hourly or 4 hourly. So that will take care of fever part, make patient comfortable. So this was another thing which was wrong in this prescription. But other thing you have to do that initially first day, second day, when you suspect tropical disease, viral disease, you will not find antigen antibody test positive. They take around 24 48 hours to get positive. In those cases, we have to look for the viral directly. We have to look for those tests which can diagnose virus directly. If we try to see the antigen or antibody, it takes time. So that's one more thing you have to remember. So as you expected, NS1 was negative, CRP was 10, ASR was 12, CBC count was normal, predominantly polymorph, 78%. Patient has 3 bout of high-grade fever with headache and nausea sensation. Goes to physician immediately after 12 hours. Physician makes paracetamol 6 hourly, adds another antibiotic, augmentin and moxifloxacin. There's another mistake somebody doing. And then he sends NS1, IgM, IgG, MP, leptospira, Vidal, urine RM, scrub, typhus, chest X-ray, everything he does. And after 24-hour patient comes, all report negative except the Vidal test is positive. Again, if in this era still you are doing Vidal test, then what I can say, Vidal test will be positive, false positive. A lot of viral, every viral test can give you Vidal positive. Vidal will be really false positive when it's not to be, and it will be false negative when it has to be. So Vidal is not a test we should do in our practice. Differential count definitely help us, which is not recorded, definitely help us in again finding what kind of infection patient has. Like if predominantly polymorphs are going up above 80%, it can be bacterial. If polymorphs are like around 60-70%, lymphocytes are getting up, and lymphocytes are more, monocytes are more, it can be predominantly viral infection. So if eosinophil count is high, it will be more of the parasitic infection. So all these things, just by differential count, you can really pinpoint from very beginning that what kind of patient infection going rather than giving irrational use of antibiotic. So same mistake done by physician, he prescribes antibiotic without finding the cause. And just for fever, you don't need to be hurry for prescribing antibiotic. Fever is not going to kill anybody. Fever is a positive response for infection. If patient do not have any other signs of with fever like very high tachycardia, tachypnea, any localized sign, high or low BP, altered sensorium, just fever, we should not be prescribing antibiotic. That's another common mistake which we do in OPD practice. So no advice for home. Again, this patient should be monitored properly at home with heart rate, blood pressure, oxygen, temperature continuously, and also given instruction when they need to get hospitalized. Anyway, most important thing for dengue, whenever dengue infection happens, for first 24 to 48 hours, it will be dengue virus component which will be positive, which is done as a form of RT-PCR, which picks up the RNA component of dengue virus, and that can diagnose. So when you suspect somebody has fever without 12 hours and you are suspecting that there's infection, better to get dengue PCR irrespective of type is primary dengue SAG. That will be more effective, more confirmatory rather than doing NS1 IgM. And NS1 will be negative very late. IgM IgG will be coming even later. Many time NS1 IgM may not be positive, only IgG will be high in after third, fourth day. So for confirming the dengue diagnosis, if you suspect somebody, it is a dengue PCR which should be done rather than NS1 IgM IgG. NS1 IgG is antigen antibody response to the body, and if dengue PCR confirms the diagnosis, you will not be using a rational antibiotic. You will be monitoring more closely. You will be looking to the CBC. You will be looking to other component which can cause dengue complication rather than looking for IgM, NS1, and IgG. Anyway, after 48 hours, continue to have fever with headache and body ache. CBC repeated, which shows hemoglobin 15 gram percent, which is high. It was initially 13 to 15. 50% lymphocyte, neutrophil 45% lymphocyte, eosinophils are 0%, lymphocytes are 3%, eosinophil 2, platelet is 1,30,000. Initially it was. So after 48 hours only, patient could not be diagnosed, but now trained it. If somebody sees this for first time, he will think this count is normal. Again, you will make the trend. So it is the trend. That's why it's very important that baseline CBC, SR, CRP should be done for all fever patients. And after 24, 48 hours, changes can really help you in guiding to reaching to a diagnosis if you are not able to reach to the diagnosis correctly in initial time. So the physician gives 1 liter of saline in clinic, injects some antibiotic again, paracetamol, send him home to come next day morning. You should never be doing this thing. When somebody has hemo concentration, when somebody has 50% drop in platelet count, even patient looks stable. high grade fever. These patients should be hospitalized. Again, this kind of mistakes happen, and you miss the train. By the time 24 hour you come, platelet has gone down, very patient and gone into coagulopathy. And most important thing, the crucial test which is more important than CBC, most of the people do not know, it is the APTT, because dengue is a disease of endothelial dysfunction. And first marker which will indicate that endothelial is getting exhausted or causing complication, or patient is going into endothelial related disease, is the APTT. Most of the time I see no physician, no general practitioner does APTT. It is such a sensitive and specific marker that your APTT started going up. It will going up before it will platelets start dropping. You should be alert, admitting the patient, monitoring it more closely. At the moment your APTT goes above 1.5 times of baseline, better to give FFP rather than giving fluid, causing more dilution, coagulopathy, and complication. So this is the situation. This kind of situation, you should be admitting the patient. Then now this patient comes after 96 hours because patient has high fever, vomiting sensation, not able to eat and drink, feeling discomfort, no response to medication, no response done last hour, no specific monitoring done at home. He's taken emergency due to abdominal discomfort. So the sign of fever which should alert, which should alarm you, the high tachycardia, tachypnea, high fever not responding to antipyretic, change in the blood report pattern, and then feeling dullness, diffuse abdominal pain. Diffuse abdominal pain is one of the most severe sign in dengue patient that indicate intestinal edema, intestinal ischemia, which happen due to endotheliopathy. And if your dengue patient is having abdominal pain, believe me, it is one of the most ominous sign, and these patients will always be admitted for close monitoring and treatment rather than sending them home. Um, uh, then this patient has was dehydrated, so I have passed less urine, his skin is dry, scratchy. And now this kind of patient, and also started getting hemorrhagic spot. So if we talk about dengue, dengue has three phases, which is classically defined: febrile, critical, and convalescent. Initially, first 24 hours to 96 hours, patient will be having only high fever, defervescence, leukopenia, increasing in hematocrit. This is the time where you need to hydrate them well. Hydrate orally. If dengue patient can take orally, he's not having nausea, vomiting sensation, prefer to give orally. If you are giving IV, monitor it very closely. The moment your patient goes from febrile to critical illness, signs of leaky thing, signs of hemoconcentrate, this is the time you have to give fluid under very close monitoring, because whatever fluid you will give, it will leak into the system and will cause more complication. So to avoid that, we need to give, and this is a time where you need to monitor APTT more closely. Give FFP at that time to keep your APTT less than 1.5 times. It will prevent the leaky it will repair the leaky endothelium. It will prevent complication, and it will allow all kind of complication which patient can have. So FFP have a potential to prevent the endothelial dysfunction, capillary leak syndrome, another complication, even thrombocytopenia. Platelet, which is the most sought after investigation in dengue, doesn't causes that much of problem. Has to be replaced even only when platelet count is less than 10,000. But what is most crucial about APTT is that it indicates early that your patient is complicated. And then third phase is convalescent phase, where there is a excessive of the fluid, excessive of capillary leak, and patient goes either in recovery or end organ dysfunction. I believe that it be managed febrile phase well, monitor patient very closely, and critical phase, that leaky, where we restrict the fluid, monitor fluid intake very closely, give crystalloid fluid which is preferably balanced or ringal lactate. Do not give fluid in leaky phase, maintain hemodynamics, let patient take orally, manage symptomatically, and give FFP early. None of these patients will go in critical phase or multi-organ dysfunction. Dengue with or without warning sign, patient who has got abdominal pain, persistent vomiting, sign of fluid accumulation anywhere in abdomen, in pleura, in pedal edema, any mucosal bleeding taken should be taken seriously. Maybe it is teeth. Even during period also, patient is if during dengue patient gets period and bleeding excessively, that should also be taken seriously. Not like it is routine bleeding, and action should be taken. Patient is very lethargy, very restless. If liver suddenly increases, or hematocrit increases suddenly, even by 1 gram, yeah, even by 3%, you need to be careful. Here you have to give control fluid and look for APTT. Severe leakage syndrome lead to shock, fluid accumulation, respiratory distress, and severe bleeding. So something which is like dengue was called severe, where there is severe leakage leading to shock. There's a bleeding which can cause hemodynamic instability or altered dysfunction. Whenever patient goes in capillary leak syndrome, at the time you should be looking for the enzyme, liver enzyme, that is both bilirubin, AST, and ALT, not only SGPT and not only the ALT. We need to look for the all three enzyme, because in dengue all three will be deranged, and we need to be careful, because if that happen, we can give N-acetylcysteine in high dose the way we use for paracetamol and prevent the liver dysfunction deterioration. So warning sign need to be very careful. Particularly, don't ignore the abdominal pain and vomiting. They are giving you signal, mucosal bleeding. Don't ignore. Be careful about that. Signs of fluid accumulation guides you not to give too much of fluid or give very guarded fluid accumulation. What will you do? Investigation, treatment, and when to admit. So this kind of patient, this patient who has got hematocrit 50%, there is a hemoconcentration need to be admitted. Total, there is a there is a low total count. Lymphocytes are high, and there is a platelet count 30,000. I'm not worried about platelet count 30,000. The moment you have thrombocytopenia, please look to the mean platelet volume. If mean platelet volume is high, in comparison to low thrombocytopenia, that means you don't need to worry. You have a 10,000 platelet count, if your main platelet volume is around 14 or 14.5, that means nothing is going to happen to the patient. If both platelet count and mean platelet volume is low, then you have to be careful about this kind of patient. If a liver dysfunction is there, you need to worry about, because you have to give N-acetylcysteine in high dose, and be careful. Most specific test is APTT. The moment it is above 1.5 times above high side, there is a hemoconcentration, and there is a platelet drop of 50%, I will start FFP immediately, which will avoid hemodilution, which will take care of the hemoconcentration, and which will even not allow the more thrombocytopenia, because it will dilute antigen antibody component, and there will be less of the platelet destruction. LDH is another marker we should be looking. The moment patient goes severe phase, we should do one baseline triglyceride and ferritin in all the patient, because in later on when this patient complicate, we need to rule out the macrophage activation syndrome. ABG is also very important in these patients with lactate, that guides us what is the metabolic status, what is the electrolyte status, and what is the lactate status. Here is the chart which you can see that in primary dengue, initially there will be viral infection. Then after 2 or 3 days, an antigen NS1 will be positive. After 2 to 3 days, an IgM will be positive, and later on IgG. But if patient has been infected with dengue previously, if same infection happen, it will protect. If other variant of dengue infect, then immediately after viral infection, NS1 will not be that high, it may be negative. What will happen that IgG will jump up. Even NS1, IgM both will be negative. So either dengue PCR will be positive, or paired sera of IgM, IgG you will find is very high. And secondary infection is more dangerous than positive infection. You need to be more careful, because these are the patients who are more likely to go in capillary leak syndrome, multi-organ dysfunction, even HLH and shock syndrome. That in fact, the best part about dengue is that if two-third, more than two-third, or maybe only 25 to 30% of the patient come with dengue, and only very deep of only 1% of them develop dengue, hemorrhagic fever, and shock. And the strategy which I'm telling you, this red thing can be converted to even white. You can completely wipe out the mortality if you take proper precaution in that. So this is a flow chart how to diagnose that your patient is having acute dengue or secondary dengue, because it's important for prognostic point of view. Also, you need to know that your patient is going to complicate it. You need to be more careful about that thing. I say that in dengue there are three death triad. One is the hemoconcentration, need to be careful. Second is capillary leak syndrome, and third is the dilution coagulopathy, which happen due to over jealous use of fluid, over excessive fluid without monitoring. As I said, that oral is the preferred one that patient can. If you at all patient has fever, vomiting sensation, you need to give very monitored fluid, and you need to balance them from input output. You cannot give 3 liter, 4 liter of fluid without monitoring if patient doesn't have shock. You need to give just maintenance fluid of 60 to 80 ml per hour. That also you need to every 12 hour monitor the intake with output. There should not be any positive fluid accumulation. There should not be any positive balance. It should be isobalanced. And this further get worsened when there is a thrombocytopenia, then you're bleeding. But believe me, in dengue, patients do not bleed because of thrombocytopenia. They believe they bleed because of the dilation coagulopathy. They bleed because there is endothelial dysfunction, and we need to repair and manage that thing. So there are four variant of dengue, as we know, four viral variant, and we need to know them because some of the variant has like Den one, sorry, Den one commonly associated with classical dengue fever, while the dengue two virus is associated with the severe disease like dengue hemorrhagic shock syndrome. So when you have a lot of dengue hemorrhagic shock syndrome in community, you should be thinking that you are dealing with this variant. Uh, the third variant is usually severe outbreak and so potential in pathogenicity, and dengue 4 is usually causes milder disease. So basically, it's a dengue 2 virus which causes more severe disease, and dengue 3 which causes more of the pandemic situation. Each serotype has multiple genetic lineage, so it should not be like that. Like you have recognized one serotype, then there are multiple variants, and that's why in every season, dengue has a different kind of presentation. And like in last season, we saw the dengue report used to come very late. Patient have symptom for 4 5 days, and then IgG used to get positive after 7 days. Symptom lasted long. So according to the different kind of genetic lineage, your symptom and response will vary. We need to be more careful because we do not have a specific treatment for this thing. As I was telling you, the dengue is the disease of endothelial dysfunction. It affects the endothelium. It with the help of the virus itself, then macrophage. They release the different kind of cytokine, even antigen NS1 and virus itself. They damage your blood vessel, lead to the capillary leak, which invites these memory cell along with neutrophil lymphocyte activation. They further damage the endothelium and lead to capillary leak syndrome. Ultimate aim of the dengue management is to prevent the damage of endothelium, and APTT is the most crucial marker of endothelial dysfunction, which will start getting up from the earliest sign much before the occult sign of dengue. Along with CBC, APTT should be done regularly in all the patients. I, in my practice, give FFP if FPT goes above 1.5 times of the baseline and avoid fluid in capillary leak syndrome. So, endothelial dysfunction, thrombocytopenia, coagulation disorder, cytokine storm, and immune complete deposition. They are the five components which combines together form the pathogenic damage what happens in dengue patient. How do I manage this patient? The first is the temperature. I do not give antipyretic as long as temperature is above below 101 degree. 100 to 101 degree temperature of the body temperature is therapeutic for dengue patient. It controls the virus replication. It boosts immune response. So we should not be damaged treating the temperature as long as it is above 101 degree. I give antipyretic and cold sponging if fever goes above 101 degree. I give paracetamol 1 gram 6 hourly or tablet 650 every 4 hourly. Do tepid sponging, switch on our air condition. Give increase air circulation around that to control the temperature. That is first thing, and hydrate the patient well, preferably orally until unless patient is drowsy, dull, or vomiting. Second thing is the fluid. Fluid component. There is a lot of talk about in the guideline about that. I follow very simple rule. If patient can take orally, is not vomiting, he will get everything orally. If patient is not taking orally, patient is vomiting, I will give IV fluid, preferably crystalline, preferably ringal lactate or physiolite as a preferred fluid because normal saline has its own complication. I will keep a ISO balance of the fluid. I will match with the urine output, and I will keep the temperature control, and I will not allow shock to happen, but I will not give too much of fluid to make him positive. We should be more worried about if patient is in shock. If hemodynamically patient is stable, patient is taking orally, don't worry about too much of the fluid. Fluid therapy, basic of fluid therapy, so mild to moderate hydration orally. If patient has shock, I will give fluid challenge of the thing. I will also look for the capillary leak syndrome. Once patient become hemodynamically stable, I may use vasopressor early, but I will be very careful in monitoring this patient. I will put early arterial line. I will put earlier I will do multiple time echo to see that patient is leaking anywhere. but I will be very, very careful because fluid kills more patient than saving in dengue patient, and you really need to be very, very careful when you are giving too much of fluid to this patient. Uh, when not to give fluid or restrict when patient is overhydrated, there is a capillary leak, patient is hemodynamically stable. During recovery phase, you don't need to give fluid, rather than you need to dehydrate the fluid. And if patient has developed critical accumulation in abdomen, in pericardium, in pleura, and patient is hemodynamically stable. Monitor during fluid therapy vital sign, heart rate, blood pressure, respiratory rate, capillary refill time. If patient is not in shock, don't give fluid. Balance, measure urine output, maintain it around 1 ml per kg per hour. Maintain hematocrit. If hematocrit is not going up, fluid urine output is okay, blood pressure is okay. You need to be very, very careful when you are giving this fluid, preferably not to give this fluid. Regular assessment. It should not be like 24 hours. Every 2 hour, 4 hour, this kind of patient who needs fluid therapy may need some monitoring, maybe as due, or maybe if your ward is well equipped with monitoring system, or maybe even ICU, but we need to be very careful in monitoring this patient. FFP and platelet, as I said, that I'm very, very strong proponent. I do not, in fact, since I started FFP in patient comes to me early, I have not known any patient I have lost due to dengue patient. And this may be overstatement, but I believe if people start doing FATT and start giving FFP, and the result will surprise you. We do not give platelet until unless it drops less than 10,000. Our main platelet volume is low, but we give FFP, a lot of FFP. And still cysteine infusion we give in all the patients who start having liver dysfunction. If enzyme goes above 3 times of the baseline, we give NAC infusion as we give for the paracetamol overdose. There is no role of steroid for treating dengue patient or dengue fever, or even capillary leak phase after dengue, but it has a role if patient develop HLH or macrophage activation syndrome, if patient has shock, physiological dose of steroid, if patient develop dengue-induced acute demyelinating encephalitis, then same the way you treat ADM, methylprednisolone. If patient develop transverse myelitis, methylprednisolone. If patient develop encephalitis, then dexamethasone. Otherwise, we should not be giving steroid to treat dengue fever or dengue-related complication until the patient has these problems. There's no role of any kind of antibiotic for dengue patient. It's one of the worst thing you can do, as long as you are dealing dengue fever, dengue shock syndrome, dengue, until the patient develop multi-organ failure. He gets secondary infection, you document, that's only time you can give antibiotic. There is no role of giving antibiotic for dengue patient. Plasmapheresis, very specially we do when this patient develop HLS syndrome, or when there's a patient develop dengue induced liver dysfunction, acute fulminant hepatic failure. That's the only time we use, or maybe dengue induced acute rheumatic encephalomyelitis. There's a time when plasmapheresis may help and salvage the patient. Can we reduce progression and prevention to complication in dengue? Yes, we can if they monitor them properly from very beginning. Focus on hemoconcentration, that is increase in hemoglobin. Focus on the capillary leak syndrome. Focus on APTT. Do not give fluid to dilute the coagulation. Give early FFP by monitoring APTT, and you can really prevent all the complications. HLH and macrophage activation syndrome should be thought of in all the patients of dengue, which comes to very profound shock, rapidly developing multi-organ dysfunction. Particularly, shock is not responding. Get your triglyceride and ferritin if they are high. Preferably, a bone marrow should be done, but it will take time. There are patients who need high dose steroid, IV gamma, or maybe because these patients are shocked, we cannot use the plasmapheresis, but give high dose steroid, and we give IV gamma to treat this condition. And even for high triglycemia, we give high dose insulin and dextrose to control the hypertriglyceridemia. So there are dengue. One more aspect of dengue that can cause any kind of complication the way other viral like GB syndrome, like encephalopathy, ADEM, transverse myelitis. We really need to monitor them, and if patient develop those diseases, should be treated in conjunction with neurophysician consult. But steroid and plasmapheresis or IV gamma can help them in reversing this condition. So, friends, I recommend you only one thing. If you go, the dengue is a disease of close monitoring. In initial phase, except paracetamol, you don't need to give anything. You need to monitor them very closely. When I say monitoring, at least every 24 hours you monitor. Even patient is at home, CBC and APTT. The moment your patient goes in hemoconsultation phase or APTT goes above baseline, admit them patient, give them FFP early. Be careful in giving fluid. Don't give too overzealous fluid to kill the patient and prevent the complication. So, a strategy to overcome challenges is enhanced diagnostic tool. You need to monitor at home. You need to have basic monitoring. You need to assess them very frequently, even on video call, even on tele home monitoring. But you need to monitor. You cannot see once and see after 24 hours your patient will worsen. Health. Another thing we need for dengue is to control the vector. That is the responsibility of government and system if they work, healthcare, and we need to train more and more people to diagnose dengue early and what to monitor. Training and monitoring is very important to save the patient from going. So this is what I'll have. Thank you for the opportunity, and I hope I could deliver the things what I needed. Thanks for the time. Hello.
Hello, sir. Thank you for this wonderful presentation. We do have some question if you like to take that up.
Yeah, I will be happy to do that. Not a problem.
So, sir, the
How
first
can,
question.
how can I see myself? I'm not cannot see.
So you need to go back to StreamYard again.
Okay.
Yeah.
Yeah.
So, sir, the first question was how can fluid management be optimized to prevent complication like dengue shock syndrome?
So look, the moment patient goes in dengue shock syndrome, you need to admit the patient in ICU. There is a multimodal monitoring. You need to put arterial line. You need to do frequent ultrasound. That means you need expert intensivists to do that. A CVP I avoid putting rather than we put peripheral line. Optimize the fluids according to need. Give frequent small bolus of challenges. Add vasopressor early. And as I said, if your ability is prolonged, give a FFP early to prevent the more capillary leak rather than giving. Don't give albumin, which is harmful to in this patient. And frequent monitoring is key. There is no one rule which I can tell you. This patient really need expert intensivist help, ICU help. Uh, Persons should be well versed in doing ultrasound bedside to assess the fluid status, and that helps the patient.
Next question is, sir, what are the emerging trends in dengue management, such as antiviral therapies or novel diagnosis tools?
So there is no antiviral right now. Vaccine has reached to a certain stage. Probably I'm expecting that because Bill and Melinda Gates Foundation is working on it very aggressively. We may get vaccine in next 1 year. It's possible. Uh, as far as the novel diagnostic is concerned, dengue PCR is something which should be done to confirm the diagnosis rather than relying on IgG, IgM, or NS1. They are not diagnostic tools.
So the next and last question is, what are the best practice for managing co-occurrent infection in the same patient?
Most of the time, if patient has, we do the tropical fever profile in this patient, at least to rule out malaria, leptospira, scrub typhus, chikungunya. If there is another viral infection, I'm not worried about. If malaria is there, you treat malaria accordingly. There can be scrub typhus, you need to give doxycycline for that. If there is a leptospira, doxycycline. So most of the time in tropical fever disease, we are not very sure. The one medicine which we prescribe empirically is doxycycline to all the patient, not moxifloxacin, not augmentin, not cefuroxime, nothing. So doxycycline takes care of the malaria, scrub typhus, even chicken, even the leptospirosis. So it is one drug which we prescribe to all the patient until the diagnosis is not confirmed.
Thank you, sir. Thank you so much for answering all our questions. That's all from our audience. Before concluding, sir, any take-home message from your end?
So I repeatedly say that in dengue APTT, the most crucial investigation has not been done by anybody. I see 100 prescription out of 100, 99 people don't do it, and that's how your patient complicate. Focus initially on diagnosing dengue by dengue PCR. Do repeated rule out hemoconcentration, that is, do repeated hemoglobin apex cell volume, and do repeated APDT. The moment your patient develop hemoconcentration, the moment your patient start developing increase in APDT, these are the patient who needs more close monitoring in hospital. Monitor them properly, and you will not lose any patient.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session.
Thank you.
Thank
Thank
you.
you for the opportunity and happy to be here. Thanks a lot.
Thank you, sir.